Good afternoon, everyone. And welcome to our Jameel Clinic seminar series. Today we have the chance or luxury to have Professor Marzyeh Ghassemi, and she'll be joined also by Hamad Adam. Just a brief intro, and I'll leave them the stage. Dr. Marzyeh Ghassemi, she's an assistant professor at MIT, at ECS and IMS, and also a Vector Institute faculty member, holding a Canadian C4AI chair and a Canada Research Chair. She holds a Herman von Helmholtz Career Development Fellowship. She was on the 35 innovator, visiting research with Alphabet Verily, and also an assistant professor at the University of Toronto. So she's been doing a number of interesting things, and she has a long bio. So I'll leave you this. You can find this more on her website. And just also a quick introduction, because she's going to be accompanied today by Hamad Adam, a PhD student also on her lab. So Marzyeh, with no further ado, please, the stage is yours. We'll leave just a few minutes maybe for questions. If there's any interruptions, maybe we can take care of it as well along the way.
Thank you, Ignacio. That's a very kind and lengthy introduction. So hi, everyone. I'm Marzyeh Ghassemi, and I'm going to talk to you today a little bit about the pre-work that my group has been doing in healthy machine learning and human health, and the motivation for the work that we've done in fair organ allocation. And then I'm going to give my graduate student, Hamad Adam, the floor, and he's actually going to walk you through the analysis that he's done so far on this project. We are in the very preliminary phases of the results, and so we appreciate feedback and comments about how to improve, because this is in no way a finished product. The goal of my lab is to create actionable insights in human health. And we were motivated by the fact in this line of work that bias is part of the clinical landscape, because doctors are humans and humans are biased. And so there's lots of clinical epidemiology work that has shown that, guess what, doctors also have biases. We believe that biased data leads to biased models. There have been many papers that demonstrate this. And then our goal is for AI to improve science and prevent medical harm. And to do that, we need improved data that is really truly diverse for research use generally. So one example that we tried recently this past year in Nature Medicine was taking the 3 large public chest X-ray data sets. So that's over 700,000 images of chest X-rays. And then we trained a DenseNet state-of-the-art machine learning model to predict a no-finding label. This is a reasonable thing that you might ask a model to do if, for example, we wanted to have a healthy triage service. I don't need to refer this patient to see a specialist because they're healthy. There's no finding, right? And then we compare the false positive rate in different subpopulations to examine model underdiagnosis. The reason we're calling it model underdiagnosis is if a machine learning model disproportionately says that, for example, female patients are healthy when they're not, they're being underdiagnosed. And if we deployed this model, then women would have a higher rate of no treatment when they need treatment. So it's a real problem. And so what we found is if you use these state-of-the-art machine learning models, we have the largest underdiagnosis rates in women, in those 0 to 20, in Black patients, and those on Medicaid insurance. And intersectional identities are often underdiagnosed even more heavily than their aggregate group. So Black or Hispanic female patients are underdiagnosed more than white female patients. And you might say, that's great. We're happy you published that paper. Doesn't this just mean that you should audit your models, right? Just show the subgroup-based performance. Let us see it. So this is a paper that I did right at the end of my PhD with my colleagues, demonstrating that when you do some of these standard prediction models, you do see gaps by ethnicity, by insurance type, and by gender. However, sometimes it's non-trivial to understand the sources of the bias and do the audit. So if you take, for example, a popular transformer word embedding model, Cybert. And so this is one of these models that has been trained on the PubMed abstract, so scientific language, and it generates text, fills in the blank in a way that is human comprehensible and very realistic. And we took a real sentence from a real clinical note here at Beth Israel Deaconess Medical Center Hospital. Blank race patient became belligerent and violent, sent to, and we're going to fill in the race, and we're going to ask Cybert to fill in the blank. When we say a Caucasian or white patient becomes belligerent or violent, then Cybert says that that person should go to the hospital. When we say that an African, African-American, or Black patient became belligerent and violent, Cybert thinks that person should go to prison. And this is not a model trained on the trash of the internet or Reddit posts. This is a model, Cybert, that is publicly available, that is being used now, right now as we speak, to score scientific abstracts, to do information retrieval, to do ranking-based lookups. And this model fills in these blanks in this way. And what we have found repeatedly, and this work will be presented at iClear in a few months by another of my graduate students, Natalie Gillerod, is that if you have a biased model and you learn a biased embedding, a biased latent space, a biased representation, there's no way to fix this downstream by just rebalancing your data, because the bias causes this asymmetry in the upstream embedding. There's no place for this new, fair, balanced data to embed to. And so when you use these bias embeddings, it impacts downstream task classification, even with rebalancing. So this isn't something that we can say, oh, the data is bad, what do? We can fix that later. It's not. It's something that we actually have to address right now, because even our fanciest debiasing methods do not work well when we have these biased embedding spaces. And so I'm going to switch gears a little bit and talk to you about this current project that we're very happy that Marzyeh Clinic founded. This is funded. This is a great opportunity for me and for my students to learn about a space I honestly knew nothing about prior to this funding. So we wanted to examine the lung transplant allocation process. And the way that this generally works is that there's a general pulmonologist who gives you a referral. They send you to a transplant center. The transplant center has a committee meeting to decide whether to list you. Then you go to the national wait list. And then there's this allocation process by which you might get a transplant. The data around who sees a pulmonologist and gets referred to a transplant center is not available. People don't just divulge that somewhere in some national database. The information at each transplant center across the United States, and there are many for each different organ system, and what those committees decide about who makes it to the waitlist is also not publicly available. What is publicly available in the UNOS data is the national waitlist information and who eventually gets a transplant. All right, and so for adults, we wanted to study what happens in the lungs. And the scoring system is based on three things: the distance between the donor and the transplant hospital. So this is in the UNOS guidelines for whether somebody should get a lung or not. The blood type compatibility, and then the lung allocation score, which is a score that should take into account the compatibility between a donor and a recipient. And we think, that this is true, right? Like the score is intended to help transplants go to the best matched patient who needs it the most, right? So if I'm doing fine and I don't need lungs for 5 years and perfect lungs come on the market that I'm a good match for, if there's somebody else who's a similarly good match and they need their lungs tomorrow, they should probably get those lungs, right? So we first did an initial investigation into who actually gets lungs. So let's say that a candidate lung comes on the market, okay? These are the real candidates that this person might match to. And they might match because they meet the criteria. The patient is within 250 miles. They have identical blood types to this donor. And we sorted the list of candidates by the LAS score, which is a score to indicate the suitability of matching, right? So if we were just going by first match, this lung would go to this person who is 171 miles away, who's an O blood type, who has a calculated LAS score of 61. But the lung actually went to this person 13, all the way down the list. And that's because there's this secret step that we were not aware of, that we became aware of during this research project. After a person is listed during the allocation, there is an organ offer. There is a lung, I have it, I offer it to your patient. The patient doesn't decide to take the lung. A physician at a transplant center decides whether to accept the lung on behalf of certain patients. And we also found that the transplant centers list people at very different volumes. So if we just take Philadelphia, UPenn listed 90 patients and transplanted 80, so that's an 89% rate. And Temple, same city, listed 161 patients and transplanted 145. And then there's a huge difference also in the transplant center acceptance. So we have very high variability center to center. So the Brigham, for example, listed 71 patients and transplanted 47. And so there are huge variability in the allocation process, how people are being listed, and the acceptance process, how many people are actually being transplanted. So where we went from here after this initial investigation is we took the UNOS lung transplant data, where we found that on average, the 5th person on the sorted list gets the available lung, median rank 5, mean rank 15, and looked at how does this additional step in the organ allocation process affect minority subgroups. If you just look at it from a purely numbers perspective, the candidates who have an estimated rank of 1 when you do that sorting are 49% female and 14% Black. Those who actually receive lungs eventually are 40% female and 10% Black. And so now I'm going to turn over the floor to my graduate student, Hamad Adam, who led a work that investigated the UNOS data and our initial findings on it. And this is joint work with Renee Barema and Leo Celli. So I'm going to swap with you here.
That's good. Thanks, Marzyeh. Great. So as Marzyeh mentioned, the key question that we want to investigate is how does this additional step, so the offer acceptance step in the transplant allocation process, affect minority subgroups, right? And we're going to look at this in 3 different ways. So the first thing we're going to look at is variability in physician acceptance decisions. The second is the structure of the existing allocation system. And the third is shortcomings in organ procurement, right? So for the first one, we actually audit the physician acceptance decisions themselves and see how these may affect different subgroups differently. So as a preface to this, I just want to point out that these kinds of decisions matter, right? So there's previous research that shows that there's a wide variance in acceptance patterns for a variety of different organ types. So there are 3 papers presented here, which looks at variabilities between different listing centers in their acceptance for lungs, livers, and hearts. The x-axis shows the average center level acceptance, so the mean center acceptance, and the y-axis shows the cumulative 1-year waitlist mortality. And so I think 2 things really jump out from all of these charts, right? The first is that centers vary really widely in their mean acceptance patterns. So from 10% to 75%, that's a really, really wide range in how many offers get accepted. And this also seems to have some association with mortality, right? Like especially in the lung case, it does seem that the less conservative you are with your acceptance, so the more patients you accept, the lower the 1-year waitlist mortality. What none of these papers really did was look at how these decisions vary by gender and race, and how different subgroups may be affected differently by these decisions. So that's what we did initially. So we did this by training a few different models to model the organ offer acceptance using a wide range of candidate and donor features, right? So here the outcome is the acceptance, yes or no. And the features in this case are a wide variety of both candidate donor and candidate donor level features. So for the candidates, we considered a variety of things, including demographics like age, gender, race, listing center, where they are, clinical characteristics like blood type, their diagnosis, what kind of transplant they need, the LAS score, which is a measure of severity, essentially, comorbidities like their BMI, smoking history, diabetes, as well as some social factors like the average income in their zip code and their social vulnerability and insurance type. We also considered a bunch of donor features, really to indicate the quality of the donor lung. So this includes age, partial pressure of oxygen, again, comorbidities like smoking and diabetes, the death mechanism, as well as a few specific lung tests that are done on the donor lung. So tests for lung or blood infection, x-rays, bronchoscopies. And then finally, the last set of features models the interactions between a specific candidate and a specific donor. The most important of these is the predicted total lung capacity, which is essentially a height ratio between the donor and the candidate. As you can imagine, a lung from a 6'6" donor may not be super great for a recipient who's 5'1", right? And so this really incorporates some of that information. The other candidate donor features include an indicator for matching gender, an indicator for matching race, as well as blood type compatibility. So all offers are made to pairs that are compatible with each other, but it does matter if the blood types are identical or merely compatible. So for example, an AA pair would be identical, but an O donor giving to an A recipient would be compatible. We look at all of this with the UNOS lung transplant data, which has for the last 10 years, 22,000 patients and about 18,000 donors. We train our machine learning models on data from 2010 to 2018. So that's our training set. And we evaluate the performance on a test set, which is just 2019 and 2020. And again, just as a reminder, we model the acceptance of an offer given all these features. In this, we only include offers that are either accepted or rejected for a few specific issues. So some offers can be rejected for things that are more logistical in nature. For example, like on that particular day, you couldn't transport the lung from the donor hospital to the recipient hospital. We don't want to consider things like that. We really want to focus on acceptances or rejections that are due to either the specific candidate or the specific donor. And so we only consider offers that are rejected for reasons that correspond to that. So things like donor age quality, size or weight, or specific issues. And in the experiments that we'll present, we'll mostly use the best model, which was the XGBoost model. We looked at a linear model, which is logistic regression, and then a random forest and an XGBoost. All these models perform relatively well. The logistic regression gets an AUC of about 0.78, the XGBoost of about 0.81. But what's more important is what they reveal in terms of the differential performance for different groups, or what they reveal about different subgroups. Great, so with that, I'll jump right into our first big result. So as I mentioned, the first thing we're looking at is variability in physician decisions, right? We want to understand how things like gender or race may affect the physician decision to accept an offer for a certain lung for a certain patient, right? So as I mentioned, we model acceptance using race, gender, and then a variety of control characteristics. The regression coefficients from this model are plotted in the table, are displayed in the table. The first column shows the unadjusted coefficient. So this is just regressing offer acceptance on the presented characteristics, so race and gender. Whereas the second column, the adjusted probability or the adjusted coefficients, show that same regression coefficient, accounting for the variety of controls. Right, so I'll make a couple of notes on this chart. The first is that in the unadjusted case, both race and gender are associated with a lower likelihood of offer acceptance, right? So on average, women and on average, Black and Hispanic patients are much less likely to have an offer accepted for them by their physician for an average lung or for the lungs that are offered to them. Right, now you might say this, there could be certain differences in the populations between, so population level differences between men and women or between Black patients and white patients that lead to this. Which is why we have that second column for the adjusted characteristics. And what we do find is that while adjusting for these covariates explains away a lot of the disparities on the gender level, it doesn't fully explain it away on the race level, right? So that racial coefficient is still negative. So a negative coefficient here means a reduced probability of acceptance. And that's still significant for Black patients, right? Even after you adjust for a variety of clinical, demographic, social features. On the sign of gender, that negative coefficient does go away. So that's the fourth row in the table, highlighted in red. And that mostly goes away because of adjusting for the height mismatch. So as I mentioned, a lung from a 6'6" donor may not be great for a 5'1" patient. And women do tend on average to be shorter than men. And so that is in large part accounts for the unadjusted disparity, which is then explained away in the adjusted. And what I want you to take away from this analysis is that there's a strong association between race and lower offer acceptance that isn't explained away by a variety of other clinical and other factors, which really tells us that these physician decisions may not be perfect, right? They may, as in a lot of other cases, be subject to some racial bias. So I'll pause there for any questions in case there are any. Otherwise, I'll dive into sort of the second two steps of our analysis. Okay, great. So I'll hop right in. So what I just told you is that these physician decisions may not be perfect, right? They may show signs of racial inequity. For the rest of these, the two next points, I kind of want you to forget about that. I kind of want you to assume that physician decisions are perfect. And what I'll argue is that even in this case, our analysis shows that there still may be some problems. There still may be some racial disparities and gender disparities. And the reason for those disparities are because of one, the structure of the existing allocation system, and two, shortcomings in organ procurement. All right, so let's start with that first one, the structure of the existing allocation system. So this next slide is really to introduce you to the way that we'll think about these problems. So as I mentioned, we trained a few different machine learning models to predict offer acceptance based on a variety of candidate and donor level features. And what we're going to use these models to do is we're going to use their predictions on the test set as an estimate of the predicted probability of acceptance for a certain candidate offered a certain lung. Right, so essentially we're using these model predictions as proxies for the probability that a given lung will be accepted by a given patient. Right? We can first compute these probabilities on the test set. So the test set, as a reminder, are the set of offers that are made in the years 2019 and 2020. So these are the actual offers that are made, and see how the predicted probability differs based on certain subgroups. Right, so for example, the chart on the right plots the distribution of the predicted probability of acceptance for the offers that are made to men and women. So men is the density plot in green, women is the density plot in red. Right, so this shows the distribution of the predicted probability of acceptance. And as you can see, the predicted probability, the distribution for females is much more right skewed than that of males. Put another way, the average woman has a much lower likelihood of having an offer accepted than the average man. And that difference is about 12%, which is significant. Now you may say,
Hamad, let me interrupt you because I think there's a question from Jenny. She's asking about the data.
yes.
The data or consideration for patients who are trans or intersex in these models, there is already significant bias discrimination in healthcare.
Yeah, that's a great question. Unfortunately, the UNOS data isn't quite granular enough to consider some of those intersectional features or to consider trans patients. I think the gender and the race categorization is relatively broad, and so it's something that we would love to look at, but it's not something that we can with the data that we have, unfortunately.
Okay, thank you, Matt.
Great. And so the results, for example, on the chart on the right shouldn't be surprising, right? This corresponds exactly to those unadjusted regression coefficients, saying that the average woman has a lower likelihood of having an offer accepted than the average man. You may say, well, okay, like, we've already shown, we know that there are differences between men and women, the clinical differences. Maybe these are explained by those clinical differences. And so is this really a problem? And what I would respond to that is that it's only a problem because the allocation system doesn't account for the differences in these acceptance probabilities, right? Currently, the allocation system within a certain geography, within a certain blood type, ranks patients by how much benefit that they would get from a lung transplant, right? Any lung transplant. The higher your expected benefit, the higher your priority. What it doesn't take into account is the probability of you accepting an offer that is made to you. And so if you're a patient who has a 10% chance of accepting an offer made to them, you're treated under the allocation system exactly the same as a patient who has a 90% chance of having an offer accepted, right? And those are very different things because naturally for the first patient, you're way less likely to actually get the transplant. To make this very, very concrete, let's look at a simple counterfactual situation, right? So as I mentioned, our machine learning models can predict the probability of having an offer accepted for any candidate and for any donor. Right, so we can use them to ask the counterfactual. What if all women in the data set were 4 inches taller? Of course, this is an implausible scenario, but I think it reveals something, right? So if all women were 4 inches taller, what would be the effect on their predicted acceptance probabilities? So the chart on the left is the same as on the previous slide, which shows the current difference between the distributions for men and women. While on the right, it shows you the difference under this counterfactual. And what you'll notice is that just increasing the height by about 4 inches really reduces that disparity. The distribution for female patients is much less right skewed, and the difference for the mean female patient between the mean male and mean female patient reduces from 12% to 8%, which is, about a third of the bias or the third of the disparity gone. And I think what I would really want you to take away, and this is something to think about, is should height make this much of a difference, right? Should a height difference of about 4 inches impact your acceptance probability by this much? The thing that we're hinting at here is that the allocation system is designed exactly the same way for patients of different height, right? But shorter patients have a much lower likelihood of having an offer accepted for them. The current system doesn't take that into account, whereas we may argue that it should, would be my opinion. But it's something to think about, whether something like this should be incorporated directly into the allocation system. It currently isn't, which is what leads to some of these gaps. Okay, so to summarize that section, the existing scores used for prioritization do not adjust for the likelihood of acceptance. They do not capture likelihood of acceptance at all. And the corollary to that is that they do not capture simple population differences, right? We know that women are on average shorter than men, and we know that height affects your offer acceptance probability, but the allocation system doesn't account for that in prioritizing certain patients higher based on if they have a lower acceptance probability. I'll pause there again in case there are any questions on that section. Otherwise, I can move on to the last piece. Okay, great. And then moving on to the last piece, which is I've labeled shortcomings in organ procurement. So using a similar style of analysis, we now have a model that can predict the likelihood of having an offer accepted for any candidate and for any donor, right? And so in an extreme case, we can use this to say, like, okay, consider another counterfactual situation. What if every organ was available to every patient, right? We weren't subject to the constraints of geography or timing or any of those logistical concerns, but you could offer any organ to any patient. What would the distribution of predicted probabilities for different subgroups look like under this very broad situation? And so that's what's plotted in the charts here. Again, on the left, it shows the difference in distributions by race, and on the right shows the difference in distributions by gender. And again, what you see is that the distributions for Black patients, as well as for female patients, are still more right skewed than those for white and male patients, right? So for example, on the left, the average Black patient still has a 5% lower likelihood of having an offer accepted for them than a white patient. So even in this most flexible situation where we're no longer subject to any logistical or other concerns, and we're also not subject to the sort of nuances of the allocation system, even in this case with the most flexible allocation system possible, there's still a gap here, right? Black and female patients are still more likely to have offers rejected, and are thus less likely to receive a lung. And what this hints at is that there might be a supply problem. And by a supply problem, what I mean is that there may be a smaller pool of lungs that are suitable for Black and female patients. In other words, suitable is in quotes there, because as in the first section, I mentioned that these physician decisions may not be perfect, but even if they are perfect, there just may be a smaller group of organs that are compatible, that are judged to be compatible for Black and female patients. And that sort of reflects a more systemic issue around the availability of organ transplants, which results directly from organ procurement patterns, which Marzyeh will touch more on.
Great. Thank you, Hamad, for covering that section of your work. He did a great job on it. And thank you guys for being patient as we virtually do an intro by me and presentation by him, and then more summary by me. So ultimately, in this initial part of our investigation, we have 4 results. So we find that there is variability in physician acceptance decisions, which is not what we would want ideally. Even if you assume that these decisions are what we want them to be, the extent of the gap is very large for the existing score systems that are used for prioritization. They do not capture the likelihood of acceptance. They also don't capture simple population differences that we would like them to account for. For example, women tend to be shorter than men.
Marzyeh,
and then,
you're answering, sorry, interrupting. You're answering this chat, right?
oh, I see.
Because I think you were talking about this, so maybe it's
how socioeconomic status and family support was captured, right? So this is one of the variables that is in the UNOS data, but again, it's not clear from the data that we have right now whether it is captured, just like with the prior question about what about trans or intersexed individuals. It isn't clear from the data that we have, which is a distillation from UNOS. It's publicly available. Anybody can ask for it. Exactly how that was created, right? And so they have tabular fields that indicate has support and things like this, but we don't know how that was assessed. And I think that that's a difficult thing in general.
And just to jump in on the specific regressions, I think the socioeconomic status was captured in terms of the household income at a zip code level, which is about the most granular it can get, which is decent proxy, but not exact. And we also captured the social vulnerability index of the zip code that the patient lives in. So we have strong proxies for socioeconomic status and social vulnerability, but of course not perfect ones.
And I think is what brings us to the last point, which is the 2 questions that were asked. We unfortunately had the same answer, which is, this is the data that we have. And it's been a little bit frustrating to realize that this data is actually very limited. And so we actually engaged with a couple of different organizations as a result of doing this, this grant to try to investigate the shortcomings in the organ procurement process more. So we worked with a former congressional staffer, Jennifer Erickson, to sign an agreement between MIT and 7 OPOs, which are the organ procurement organizations. So remember, I first revealed that there was a process, and then I revealed that there was an extra step in the process. I will now reveal to you that there was even an extra step in this process that we were not aware of. So what happens is the general pulmonologist refers you to the transplant center, who decides in a committee meeting whether you can be sent to the national wait list. The national wait list then does the allocation process with the organ offer. This is the data that we presented on today, and has an eventual transplant and transplant acceptance. There's this extra step here on organ procurement. Where do these even come from, and how do we capture the suitability of an organ? Because one reason that we found that organs were sometimes rejected for example, a female candidate or a minority candidate, is that it wasn't suitable. The lung was marginal, for example, but then it was given to somebody else who maybe was in better health. And how that is assessed and how these organs are procured is actually a topic of great focus currently in our healthcare system. So we're working with the Federation of American scientists to assess the realities of the organ procurement process by working with these initially 7 organ procurement organizations across the United States that have donated their records for this process. Our initial results on these centers that have currently done the data transfer to our lab is that there are also huge inefficiencies here. And this is an important area that before working on this topic, before getting this grant, before starting this research, I had no clue about. And now I'm investing some significant focus on, because I don't think in this situation, there are some problems that, I presented in the front matter. there are some problems that I think serious machine learning techniques really can and should address. And in this problem specifically, I think this is where machine learning really audits well, right? So it's shining as an auditing tool where if we can reveal that there are differences that should not be occurring based on the current scores that we have, those are things that we can make an honest recommendation to the OPOs and the Federation of American Scientists and potentially have changed as a policy measure. I see a question, so I'm just going to open the chat again. Oh, yes. Okay. Yes. Thank you. Yeah. And so our goals out of this research and the next steps that we would like to focus on are first, some non-technical advice. We really want to improve the guidelines and scoring for more consistent processes with UNOS. This, organ allocation is a well-studied economics problem, but it really hasn't been studied as we showed in the front matter from this sort of bias and equity lens, which was surprising to me, given that there is so much inequity in the process. We want to have some specific recommendations we can make coming out of this research directly. So can we define a list of attributes that make an organ marginal? Can we say that there are process differences that have been demonstrated to influence that judgment? Can we provide some data-driven recommendations to remove this variation of the average 15th, median 15th rank person in this list that's supposed to be sorted by the score gets a lung? And we would like to recommend that some of these processes be explicitly focused on equity, given that this is a surprising and major result of our initial investigations. With the data that we have, studying variation is very difficult because we don't have identification of physician attributes. So we don't know, for example, that certain physicians maybe are driving this. And that's something where we would like to partner with transplant centers and get some of this information in the same way that we've partnered with OPOs to say, we'll de-identify your data. We're not going to name you as an institution that does bad work. We want to understand these factors so that we can drive change across the board. We know that procurement is very challenging. Organ approach and collection is a sensitive issue. Our initial results in the data that we have mirror what we see in the literature, which is that minority patients are often given less focus in approaches for organ procurements. And some of the people that we've spoken to in these organizations have told us privately that they feel less comfortable maybe with doing the approach. I am comfortable approaching somebody who looks like me and saying your family member is dying. Would you like to consider organ donation for them? It will help a lot of people. But if you look different than I do, then maybe I just assume you would not be comfortable with it. But what that leads to, as we showed previously, is fewer organs in the total pool that are suitable for other minority candidates, right? Because some of this match is due to blood types that may be more or less common in different subgroups, existing conditions that may be more or less common in certain subgroups. And so having a smaller possible pool of organs that are donated from minority individuals means that minority individuals who need organs are at a significant disadvantage in our analysis, and then also anecdotally from who we speak to. And finally, we think that there's the potential for more detailed analysis if UNOS records could be expanded or augmented, as both of the questions indicated today. There is no information about inter or transsex individuals. There is no information about individual level social vulnerability or socioeconomic status. This is sort of an aggregate metric that we're provided with. And so we do think that there is some exciting work that we'd like to move forward with here. And I'll end there saying that this was the work of Hamad Adam, who is a fantastic PhD student in the group. But that generally, he's been working with several other people in the group who are all working towards this idea of creating actionable insights in human health. And I'm happy to take any more questions. We would love your ideas or comments because, as I said, this is a completely new direction for me. I never worked with organ allocation or procurement data or thought about it even from a clinical perspective until this project was funded. And so if there are others who have ideas, we'd love to hear them. I see it, chat.
Yeah, and thank you very much, Marzyeh. That was fantastic. And Hamad, and yeah, we're gonna see some questions on the chat, and maybe we start also with
So there's one here that says, are all donor lungs treated as equivalent in the model? Living versus deceased donor, uni versus bilateral? And two, do you think that the recent trend in the number of available organs, moving average or length of the waitlist affects decisions? So in reverse order, yes, I do think that the trend in the number of available organs will affect the length of the waitlist decisions. We need to get the more updated data in order to verify that, but I worry that it will affect the length of the waitlist decisions for the people that we have already seen get these organs disproportionately. And so I don't think that just attacking that part of the problem will fix this, because I was surprised at still consistently seeing an equity gap in allocation. In the model, I think we do.
So we only look at deceased lungs.
Yeah.
So living lung transplantation is really difficult.
Yeah.
And so it's just deceased lungs.
And so this was something that our clinical collaborator, Renee Barema, actually advised. He said, you don't want to look at the living lung transplants.
Yeah. And then with the number of available organs, I think where that really comes in is in the actual allocation process, which sort of ranks patients and then decides, okay, like this person gets an offer at this point. Once the offer is made, that decision is made independently of the waitlist. I think what may affect that decision is if you think, okay, a better organ may come tomorrow, then that's really where you may have some of those, but it's hard to account for those.
We also had some feedback from, again, our clinical collaborators at transplant centers saying, surgeons are scored based on their transplant success rate. So there's a national scoring system, right? And so if I, for example, am at a prestigious academic medical center and I'm only on service for a couple of weeks every few months, right? Because I've bought out the rest of my clinical service doing research work. I only have a few opportunities to have a transplant. And if I botch any of those, or, the official metric for this is the 30-day mortality, right? Or then the 1-year mortality. And so if any of those fail, then my numbers go way down and I'm not doing a volume of transplants. And so my score will be negatively impacted in a way I may not be able to recover from. And so his comment, our collaborator's comment, was you see some people who are more academic, right? And they're at these fancier sort of academic medical centers, choose to only allocate organs to those who they think are just very, very, very likely to accept them and be healthy within a year. They don't want any chance at all of any sort of rejection, which is not really what, the lung allocation score is there for a reason. It really should be matching these organs to the best potential candidates, but there's all of this extra human social decision-making that's going into play. And absent any guidelines that, sort of penalize you for only giving these organs to the healthiest of the healthiest, which tend to disproportionately be very healthy white men, you are going to give them to people who you think have the best chance of surviving so that your own surgical success scores don't go down, unfortunately. Another question, if you make a proposal for changing the allocation scheme, how do you plan to infer its effect on waitlist decisions downstream, modeling, RCT, and other approach? I think if our recommendations are taken up, they will probably not be taken up uniformly with the same vigor and consistency. And so, for example, you can see there's the greatest natural RCT ever in the world was when different vaccines were available in different countries for the pandemic, right? And that was not planned. That was just a logistics, supply, and national policy experiment. And so I think here too, if, for example, we were able to collaborate with UNOS and the Federation of American Scientists and put out a recommendation for having the allocation scheme be modified or steps added to it for arbitration, assessment of marginality, an audit of, distance from top candidate that you consistently allocate organs to, I don't think all centers would uniformly take those. And I do think that would then be a very exciting natural RCT to look at.
Yeah, and before that, I think evaluating any waitlist or any update to a policy would have to be backed by extensive modeling. I think initially, like,
Yeah.
For example, one approach would be, maybe you want to weight the priorities by the predicted likelihood of acceptance in the future, right? Anything like that, I think, to make its case would have to be would borne out in an extensive simulation model before we sort of actually advised it, I think. But that's something we're hoping to do.
Absolutely, because it looks to me that getting to the policy space could be something that could be really impactful here, right?
We were really excited by the findings, really. Like, it's again, it's very rare, I think, as a faculty member that you try a short project, a short research project in a new space and are just blown away by what you didn't know. And that was definitely the case for me here. And I don't know, Hamad, for you as well, maybe. But I think it's one of those, again, sometimes there is an intractability of using machine learning in practice to improve something because the process is too difficult, the barriers are too great, or whatever it is. And in this case, I have been very pleasantly surprised to see that I can see actual policy levers that could be created or constructed or implemented that would potentially positively affect this issue. Because it shouldn't stand this way, right? It's a known issue. Our analysis just confirms that while it is a known issue in aggregate, it is a specific issue for women and minorities, and we don't want this inequity to continue.
That's a very good answer. Yeah, thank you very much. Let's see if there's more questions.
Hi, this is Tanai. I'm a lung doctor at the VCU. So it's very interesting that you find the discrepancy in terms of the organ allocation. So the question I have is, do you have data breakdown into institutions? Because for the lung transplant, as I know, there's not many centers that contribute more than 100 transplants per year. So there could be like outliers, let's say Duke, Jameel Clinic, Temple, or some others that do a lot of transplant, and that could contribute to like different in the data. Thank you.
Yeah, absolutely. So I think in our so the results that we present here are in aggregate, so averages across all centers. We do model an effect for a listing center. So in the linear model, we have a fixed effect for a listing center, which sort of accounts for the fact that different listing centers have very different practices. But we don't sort of report our results broken down by listing center, but I think it's definitely a valuable thing for us to look at going forward.
So one of the things that we were wondering about, and maybe you have an opinion or a perspective on this, is whether we should try to look at some of these results broken down by centers. We, one of the things we don't want to do is call out specific individuals or places. We wanted to present sort of a policy lever that would apply to all, because I feel like the incentive structure here is actually quite poor, right? Like, you are incentivized to have very good transplant success numbers, and you're incentivized to sort of do this volume with the matching. And also there is very little guidance on how you assess marginality and whether it's appropriate for you to routinely go 13 to 15 people down a list. Whether it makes sense for a patient to perhaps weigh in on the fact that you as a physician are rejecting a lung on their behalf. And so I think some of those questions are much higher level, but I do think it would be interesting to split our analysis up. We just didn't want anybody to feel too called out.
Yeah, I understand, because I think as far as a practice, the lung transplant center, they have a committee, and the practice in each institute would be along the same line. But I think that as for individual physician, I don't think that much different, but it would be interesting to look at each center. I know that it's political to say it's not like you want to point out each center have a different practice, but it may contribute to their the differences in terms of the gender and also on the socioeconomic status. I think that made into play, because each center have different geographic, and some of them located in more, let's say, Black population, or some of them into the white community. So again, I had a patient that they know that they need to get transplant. They just move to the place that close to the center that they have a higher chance of getting organs.
Yeah, we've heard that.
Yeah,
we've heard
so I
that
think it
a
would be interesting
lot.
to look at it. Yeah, to look at the institutions.
So we've heard quite a bit that many anecdotal examples of patients going to a center and they're denied the listing, and they just go to another center and then they're immediately listed. And so this variation it does seem
that's definitely correct. Yeah, it's a transplant world that happened in all the organs. Thank you. Very nice.
Which of course limits the options of the ones that are not doing this, but now we are just
yeah.
We need to do some changes here, I can tell.
Other questions or suggestions? We're very happy to hear suggestions. All right, well, thank you very much for listening. This has been a very fun project to engage in, and it's now a full direction that I have an entirely new data set and research question in mind for, because I, investigated this with Hamad based on this. So I think that the Jameel Clinic community is really fantastic, and I'm very happy that we were able to receive this grant.
Thank you so much, Marzyeh and Hamad.